Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. One of the world's most contagious diseases is making a comeback in the United States. And while today's doctors have studied measles in training, most have not treated the infection in a human. I'll be talking about measles identification and treatment with Dr. Danielle Daniels. She's an assistant professor of pediatrics at Upstate, specializing in infectious disease. Welcome to the Informed Patient, Dr. Daniels.
Thank you so much for having me.
More than 1,200 cases of measles have been logged in the U.S. this year, which is more than half the total number for all of 2025. Are there projections for how many more cases we may see?
This is a very concerning trend. I think the good news about this is we really have an excellent tool to stop it. And so 2 doses of our measles vaccine is 97% protective. And if we can reach 95% or more of a community remaining vaccinated, that's enough to prevent the ongoing spread within a community. So unfortunately, we are seeing a decline in the vaccination rates below that 95% mark. And that's what's allowing these local outbreaks to occur. So if you look at some of the modeling studies, they've predicted that just a 10% decline in MMR vaccination rates may result in over 11 million cases of measles in the upcoming 25 years. So that's a lot of cases to come if we continue to see a decline in vaccination rates.
Now, during COVID, hospitals had specialized units just for COVID patients. Do you know if that's happening in areas where there are these bigger outbreaks of measles?
Not currently, but I do think that every medical center should really have a plan in place for when they encounter these measles cases. So this is a highly contagious viral infection. It may look like other viral infections early in its course. And so in areas that are experiencing an outbreak, they really should be screening for these patients when they first come in contact with the medical system. So I think we're familiar with this process a little bit when, we had COVID screening that was happening. I think everyone can remember those COVID questionnaires that were coming to them when they arrived at the doctor's office or even over the phone. And so similarly, we're going to be, hearing those sort of questions, but targeting measles in areas that are experiencing outbreaks. And so we really need to have plans in place to identify these patients early on.
What makes measles so contagious? How does it spread?
Yeah, so measles is one of the most contagious infectious diseases that we know of. It has a basic reproduction number, or an R naught, of 12 to 18. So what that means is that on average, a single person who's infected with measles can transmit that virus up to 18 others within a susceptible community. And so 9 out of 10 people who are exposed to measles but don't have immunity are going to develop that measles infection after they're exposed. That's a big number. So this virus is so contagious, it can remain active in the air of enclosed spaces for up to 2 hours after an infected individual is breathing in that space. And so these are, some of the factors that play into why it's so contagious and why we need to have a healthy fear of it.
So a child, let's say a teenager at school, who's positive for this or has measles, could infect their classroom, but then also the class that comes into that room after they leave to another, because it's still
Yeah,
in the air potentially?
exactly. So it can linger in the air for up to 2 hours after. Again, we're talking about for those who don't have immunity. So if they're not vaccinated, if they haven't been previously exposed, those are the patients, the children who are at risk. And it's really, measles is going to be transmitted through airborne spread. So when an infected individual is breathing in or out, they're coughing, they're sneezing, or by direct contact with those respiratory droplets. That's how it's going to spread to other individuals. And so it's not only those big droplets that we worry about coming in contact with physically, but it might be the very small particles that are in the air and floating in the air for up to 2 hours after.
So how long after exposure until a person who's not protected would develop symptoms?
Typically, that's going to be 11 to 12 days from the time of the initial exposure to when they have the first onset of symptoms. So it's going to be even after that that they start to develop that characteristic rash that we'll typically hear about. And we're really going to be contagious from 4 days before that rash comes until 4 days after. And so that's a little over a week that these patients are contagious and potentially spreading it to others around them.
And not even knowing that they're infected.
Yep, possibly in the beginning without that rash, when they have some of those prodromal symptoms.
What are the symptoms other than the rash? Is there anything else to be looking out for?
Measles typically starts with a fever, and that fever can be quite high as well. And so, we're talking up to 104 or 105. And then, in addition to the fever, they can have one of these three C's that we talk about. You'll hear in the medical school books, we say the three C's are cough, coryza, or conjunctivitis. So, cough is self explanatory. Coryza just means a runny nose. And then conjunctivitis means watery, goopy eyes. And so we're going to see the fever and usually one of those three symptoms coming along with it. And those can start 4 days before that characteristic rash. The rash that we see, usually coming 4 days after those initial symptoms, sometimes that looks, red and slightly raised. It usually starts on the head and then will usually spread down to your trunk and then your arms and legs, the rest of the body.
This is Upstate's The Informed Patient Podcast. I'm your host, Amber Smith. I'm talking with Pediatrician Danielle Daniels, who specializes in infectious disease, and we're talking about measles in children. There's a belief out there that measles is no big deal, that it's sort of a mild illness or a bad cold and no cause for alarm. When do you recommend parents seek medical care for a child with symptoms?
I think it's a challenging thing because many of us live in a world where we're not familiar with this infection, and that's a wonderful thing. But because we're not familiar with it, we underestimate the dangers that can be associated with this infection, and we can minimize the damage that it can do to our health, not only in the short term, but the long term. And so complications of this virus are pretty frequent. So they can occur in 1/3 of patients who have measles, and they can be severe. Traditionally, we've seen up to 1 in 4 can be hospitalized with acute measles infection. And though last year, the reports that we've seen in the United States, it was slightly lower than that. There's still very high percentages. And so if your child is developing signs of fever and the other symptoms we were talking about, and you fear that they've been exposed to measles and they're prone to this because they don't have immunity, then they really should be tested and evaluated at that time. So not all children who have measles infection will need to be hospitalized, but it's important that if we know they have measles infection, that they should remain isolated until they're not going to, infect other individuals. And then as they're at home, I think that's when we're looking for complications that may require extra help. And so that would be things like dehydration that can develop from diarrhea, that can be breathing trouble that develops from pneumonia, that can be antibiotics that are needed for an ear infection, all things that we see commonly in children who are infected with measles.
Is this tricky for doctors to diagnose if they've never seen actual patients with measles?
Yeah, so I think recognition is probably the first thing that we need to become more familiar with. And so knowing if measles is circulating in our community, asking about that vaccination history to identify those who are at highest risk, and even asking about a travel history, because now there are many parts of even our country that you can travel to and come back and spread measles. So I think those are all important for us as the practitioners who are seeing the patients. And then once we have that concern for measles, that's when we're going to be reaching out to our local health departments and working quickly and efficiently with them to make this diagnosis. So the way it's actually going to be diagnosed is we're going to be doing a PCR test. I think during COVID, we all got familiar with some of the PCR tests, which are like the nasal swab or the throat swab, picking up the actual virus itself. And then sometimes a blood test as well to look for antibodies, our body's protection and response to the virus. So those are two ways that we usually make this diagnosis.
Now, are people who have been exposed to the child who's infected, if they are vaccinated or were vaccinated as children, are they considered safe to be around that child?
So for those who have immunity, they're the ones who are going to have protection. And so if you look at how we treat those who come in contact with the measles virus and which patients we're going to worry about going out and developing symptoms and spreading it to, it's really those who don't have immunity. If you look at the cases that we've seen here in the US over the past year, 92 to 94% of them are unvaccinated or have unknown vaccine status. So that's the vast majority of the cases that we're seeing here are those who don't have protection.
Now, are some of the remaining cases people who have compromised immunity or an immune system that's not functioning properly?
Of those who are remaining, there's those who only have one vaccine. And so that's one of the reasons why we do a 2-dose series. What you'll see is with the 1 dose of measles vaccine, that's about 93% effective. And then with 2 doses, that brings us up to 97%. So we're catching additional, people by administering that second dose. And then there are also those who can't be vaccinated because they have underlying weakened immune systems, or they can't be vaccinated because of their age. We don't routinely vaccinate children under the age of 1. And so these are all things to think about in those who are vulnerable in our community.
You mentioned the public health department, so I know they have a role in some of this, but let me ask you if there's an outbreak in your area and you are not immune, you haven't been vaccinated, but you find out that you were exposed, you were around someone who has tested positive. Is it too late then? Or is there anything you can do to try to prevent the development of
Yeah.
measles?
Yeah, that's a great question. So I think as soon as you are aware that you have been exposed to someone with measles, and you understand that you are not immune, you should reach out right away, because it really is time dependent on, if we can give you that protection following the exposure. So the first 72 hours after exposure is the period of time where it would be most effective to get you vaccinated and still provide protection against this infection. When you get to that 4 to 6 day range, there are some situations where we can provide immunoglobulin. So that's formed antibodies to those who are not protected and maybe immunocompromised. And then, really, beyond that, it's more of a waiting game. And so, if you know you've been exposed, I would say act early on in seeking, post exposure prophylaxis. That's what we call it.
Now, getting back to possible complications, I've read about liver inflammation, anemia, encephalitis. Are you able to predict which child will have which complication?
No, it's really challenging to predict which children are going to go on to develop these complications, which is why we recommend universally vaccinating. There are high risk groups, and so certainly children under 5 years of age, and then even adults older than 20 are some of those higher risk groups for complications. Pregnant individuals, patients with weakened immune systems, who again may not be able to get, vaccinated depending on their underlying immunity. But even in the absence of those risk factors, a child can develop complications from this infection.
What is measles caused immune amnesia?
This is one of those under-recognized complications of measles infection. So when we get the measles virus, it can directly infect our memory cells that help protect us against infections. So these memory T and B cells, they really are needed to remember which infections, which vaccines we've received in our past, so that when we are exposed to them, they start quickly working and protect us. When we have the measles virus, this measles virus directly attacks those memory cells. And by depleting them, we're essentially erasing our immune system's memory to some of these previously encountered infections. And so this impact on those cells, this, depletion of those cells can actually last for 2 to 3 years, sometimes even longer after a measles infection. And so it's really putting you at risk not only now, but later on for developing secondary bacterial or viral infections.
How is measles typically treated?
We unfortunately don't have an antiviral medicine for measles. So we don't have a specific medicine to treat measles itself, which is unfortunate. And that's why prevention is has a big role here. We really are supporting patients through the complications of measles. And so that means if they develop pneumonia, treating them for that, secondary bacterial infections, they might need antibiotics, they might need oxygen, they might need fluids to help them with dehydration. And then there is a role in vitamin A supplementation for children with measles. And that is not to prevent infection, that is not to treat infection, but it may help reduce the risk of complications for children who have been infected. And so it's really important that that's administered with your provider because we've also seen cases of vitamin A toxicity from children who have taken too much. So it really, it's being used as a tool to try to prevent complications, but needs to be done appropriately.
So it sounds like this is the kind of thing that needs to really be diagnosed by your pediatrician or your provider, but the majority of kids with measles are treated in the home?
I mentioned this a little bit earlier, but I think among the cases last year, 11% were hospitalized. So that's still 1 in 10. That's a big number when you look at other infections. But that does mean that a lot of patients are going to be in the home isolating with this virus.
And so parents maybe, fluids, rest. I mean,
Mhm.
what are the other is there any other advice for how to keep your child as comfortable as possible?
I'll quote one of my mentors quoting his mentor. They said that children with measles look measly. So, they're feeling unwell. And so, if you've ever nursed your child back to health during a cold, I would say those are all the things you need to be doing. So, you can give them medicine to make them more comfortable as far as fever medicines. You can make sure that they're well hydrated, and then I think if you're concerned for the way they're breathing, for the, not being able to keep up their fluid intake, um, and then, in general, if there's things that are making you uncomfortable, that's a sign to get them evaluated because some of these complications may need treatment on top of just those supportive care measures.
Now, some of today's parents might not remember if they were fully vaccinated back when they were children. Is there any concern about transmission to the parent or the grandparent? Or, and I know you do pediatrics, but do you know if there's anything that parents and grandparents can do to make sure that they're immune?
It's important to recognize your own vaccine history, your own immunity, whether or not you have received the vaccine. If you were born before the 1960s, before 1958, it's likely that you had natural immunity. You probably were exposed at that point. But then there was also a period of time where, beyond that, you should have received a vaccine. And so I think but prior to implementation of the 2-dose series, that's where, growing up, you may have only received 1 dose. A grandparent may have only received 1 dose of vaccine. And we've talked a little bit about how that's 93% effective, but there's a subset of individuals who may still not have immunity at that stage. So if you are exposed to measles, that's where it's important to work with and talk with your healthcare provider, and they can help you determine your own immune status. If you're uncertain of that, then certainly I would say, to be safe, revaccination is the way to go.
You're listening to Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking about measles with pediatrician Danielle Daniels, who specializes in infectious disease at Upstate. Let's talk about how to protect children from measles. Vaccination began in the 1960s and it's evolved over time. What can you tell us about today's measles vaccine?
The measles vaccine is a live attenuated virus vaccine. So basically, what this means is it's a weakened version of the virus that really allows your body to safely encounter and then develop a protective response to that virus without all of those feared complications that we discussed earlier. And so today it's typically given as the MMR, the measles, mumps, rubella vaccine, or the MMRV, measles, mumps, rubella, varicella vaccine. And so individual vaccines for measles, mumps, and rubella have not been available in the US since they were phased out in the late 2000s, so 2009. So really, this is how we give and we protect against measles today.
And did you say it's like 97% effective if you
Yeah,
get
so
both
yep,
doses?
when you have 2 doses, it's 97% effective.
How safe is the vaccine? I think a lot of parents are concerned about that.
The MMR vaccine is very safe. There are some mild adverse events that we experience, and so most of the time, we're gonna see that as soreness or redness at the injection site, a mild rash or fever, and then sometimes some temporary joint pain or stiffness. And there are more rare side effects, very rare side effects that we see, such as febrile seizure, and that's 1 in every 3,000 to 4,000 patients. But as we discussed, the complications from measles infection itself are very, far more common and definitely more severe with lasting consequences that can include, we talked about immune amnesia a little bit. We didn't talk about all of those neurologic complications that can develop, and then even death. And so I think in looking at the risk of the vaccines, we've talked about, they're very minimal and very safe. And then looking at the risks of the actual disease itself can be quite severe. I'll also say that studies have found no credible link between the MMR vaccine and autism. And so I'll throw that out there as well. I know that's one of the common concerns that we hear.
That's not a concern for any children, that they would develop autism because of a measles vaccine?
No, this really began according to some misinformation. Dr. Andrew Wakefield, who had published an article that had since been taken down, it was retracted. The data again and again has come back to show that this is not a credible link.
Is it true that babies are not recommended to be vaccinated until 12 to 15 months?
Yeah, so the first routine dose of measles vaccine is given at 12 to 15 months of age. And so infants, when they're first born, they have protection from maternal antibodies that cross over from the placenta. And so this protection is, really present from the time they're born, but it's going to wane over time. And so, as this protection wanes, our bodies are then ready to develop their own response. And that's why we administer the vaccine at that age. There are infants who, as early as 6 months, may be traveling abroad or traveling even to an area that has local measles outbreak. And so it's safe to give it to them, but it may not be as effective when you're giving it that early. And so that's where if you're giving it to a 6 or 7 month olds anytime between 6 and 12 months, you really do want to give it again at 12 months and 4 to 6 years, as we routinely recommend.
For someone whose parents did not vaccinate them, is it too late?
No, it's never too late. So I would say, young adults can absolutely be vaccinated and they should get their vaccines, especially as we're seeing more and more cases. I talked a little bit about adults over 20 are one of those high risk groups for complications as well. And so I would say if you have not had a measles vaccine, that I would highly recommend, strongly recommend going and getting that.
Does anyone ever need a booster? Someone who's older and was vaccinated as a child and they're in their 60s or 70s or 80s. I mean, does the measles protect you for life?
Yeah, so it depends. I would say natural immunity, it does produce a robust response that is expected to be lifelong. I would say there was a period of time, a short period during the 1960s where an inactivated vaccine was used, and that one does not produce as long of a response. So if you were vaccinated with that one, I would certainly say it would be worth getting a booster shot. And then we talked about, you may, if you only received one dose, you may not know if you have lasting immunity. And so that's where you may not have responded initially. And that's where you may benefit from a booster response as well. There's two different concepts here. So you may not have initially responded to the vaccine. So that's that subset, the 7% that we're talking about. But there's also can be some waning of the protection over time. And so that's where high risk individuals, if you have been exposed, it's worth a discussion with your doctor.
Now, measles was declared eliminated from the United States in the year 2000. Do you fear that current outbreaks are going to jeopardize that status?
Yes, absolutely. So measles elimination, if we look at the definition of that, it's defined as the absence of local measles viral transmission for more than 12 months in an area. And so the US elimination status, it's going to be reviewed later this year. And I think it's anticipated that we will lose our status at that time, especially if the current trend continues. The rise that we're seeing in the measles isn't just limited to here in the US. I think globally, several countries have lost their elimination status in the past 6 months. So that includes Canada, many European countries like the UK and Spain. And it's really true that measles anywhere is a threat everywhere. And so if you're seeing circulation in other parts of the world, it can happen here too.
How would we go about regaining that status if we lose it? Is it just the matter of getting more people vaccinated?
Yeah, that's a huge part of it. So if we can get over 95% of a population vaccinated, then I think we can stop that local spread within. And so that's really what we need to strive to achieve here in order to regain that status to stop this spread from occurring. Because as I said, measles anywhere is a threat everywhere. So even if we were to somehow have no more cases here, it just takes a plane ride to bring it back. And then it continues to spread in populations where that immunity drops below the recommended amount.
Well, Dr. Daniels, thank you so much for making time for this interview.
Of course. Thanks for having me.
My guest has been Dr. Danielle Daniels, an assistant professor of pediatrics at Upstate specializing in infectious disease. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.